we will stream it to YouTube. So just give me a second. I'm sure one of our most widely viewed videos is this meeting and post. There we go. Okay. Excellent. So thanks for joining today. I know it's been a little bit since we've met last, and but we definitely appreciate you guys being here. And I just saw one email come in. I know Ben Oakfield's not going to be joining, but he provided some feedback already, which we're greatly appreciative of. So we will spend a little bit of time. I know it took us a little longer getting the People Served dashboard out to folks than we'd hoped. With that said, we welcome your feedback still as we work out the kinks and also look to launch future dashboards moving forward and kind of continue on the plan. So the commissioner has been following along as well. She won't be joining today, has a conflicting meeting, but she's been actively interested, and she's very interested in seeing us continue to move this forward. Susan, anything else you want to add before we kind of dive into anything?
Sorry, having a little trouble getting off of mute. No, just excited to be meeting with folks again and look forward to folks' feedback and input.
Great. And we're joined today. So we'll spend a little time just, again, offering opportunities to talk about the dashboard, getting some other, we'll provide some other high-level updates. And then we're joined by CHNCT's Chief Medical Officer, Dr. McGraw, who will be providing a overview of some of the dashboards, similar to last time where we had Benecare, our dental administrative service organization, with Lisa Rhoda, and some helpful commentary by Donna, who's on today as well, about their dashboarding. We'll be doing a similar thing just to kind of inform everybody here about what dashboarding work is currently going on related to DSS services, and hopefully provide you with some thoughts that you can then reflect back to us, or just inform you better about things that are currently going on. So with that said, I know we have our 2 hours. I'm not sure we will likely need that total amount of time. With that said, if we do, we're have it scheduled. It probably depends on how much feedback folks have about the existing People Served dashboard launch and any other dashboard updates. So this is we're going to jump right in. And if folks haven't had a chance to look at it too much, feel free to pull it up. It should be in the email that was sent out. And actually, Bonnie, one question do you have the link to the dashboard? I realized I know we recognize you may have gotten left off the last invite. So did you get that link or no?
I was going to follow up with you after. I still need the link.
Okay.
And I'll review. Thank you so much.
Okay, no problem. I will make sure we get that to you. Actually, I'll forward it to you right now while we're on, Bonnie, just so you have it.
Thanks so much, everyone.
So with that, any initial reactions to this? I know we kind of previewed this previously, but now you can actually play around with it a little bit. Again, Ben Oakfield just sent us some comments, things that you like about it, things you'd like to see different. Obviously, there's some limitations what we're able to do, but regardless, feedback about how it's formatting, structure, how we're displaying it, anything. So feel free to kick off conversation. Feel free to raise your hand or just jump in at this point.
I had just a couple of really minor things that I noticed. One was that it would be helpful to know when the date was that it was last updated, a specific date. And I don't know what the plan is for updating this, but the People Served data that had been on the open data portal was being updated monthly. So if that's the case, it would just be nice to know how recent this is, if there is current year data especially. And then also the ability to download to download the raw data. So for example, we had talked about this last time, you can't look at anything longitudinally in this system, but if there were an opportunity to download some of the tables, people could do that on their own. And that's the way, you know, just not to lose functionality that we did have. This is much more user friendly than the raw data in the open data portal, but it would be nice not to lose that ability to look at things over time.
So I can answer a couple things for you, Karen. The 2022 data is not up there yet, but it will be added. So we are looking at maintaining the same schedule. The individual who updates both the static version and this has been away, has been out. And so once he returns, the intention is to update that on a monthly basis as well. So then that's when we would obviously, so this is update as to related to the calendar year 2021 data. So that's the most recent, but the 2022, once that's added, the information will be reflected as such. You can download the aggregate data for each of the tiles. So if you if you go to the website and there's a little button on the right hand side that says download, and if you click on crosstab, so it'll crosstab and then it'll show you the various tiles. You'll have to scroll horizontally to see them all. But if you wanted to for example, see it at the town level, you click on that particular tile, you click on crosstab, and you can choose Excel or CSV as the download option.
Nice, thank you. I missed that. I didn't find it, so thank you.
And just also one of the other things, we wanted to obviously get this up, and we needed to make sure we were clear on the functionality. I am working with our Office of Skill Development to actually create a short video so that for folks, in addition to the guide that's linked to the dash, we're also going to do a short video both in English and Spanish that will give people basic navigation and go over some of those high level about kind of what you click on, how do you use a filter, how do you deactivate a filter, how do you export, and all those kinds of things. So that's in the work as well.
Thank you, Susan.
You're welcome.
Grace?
Yeah, so that as a follow-up to the last two comments, I agree that it would be helpful to have, I mean, I was able to get around it and I kind of enjoyed it. And so my first comment is congratulations, because there's a lot you've done to make it interactive and, informative. I think for folks that are less facile, or any of us, because as Karen said, she missed something. The basics of go to this next, besides a separate video, I don't know if there's an easy way to embed some of it. One thing happened to me, for example, is I looked up a town and then I was trying to get back to Connecticut as a complete state, and it didn't seem intuitive to figure out how to do that. So there may be things that just need to be sort of pop-ups to help people know what to do next in some cases, but that's probably another layer you're getting to.
Yeah,
Otherwise, I really appreciate what you've got here.
Thank you.
Thank you, Grace. Kelly?
Sorry, didn't realize my video was up. Just something that I don't know how many of the providers on the call know. So under race, the 180,998 unknowns, it has become glaringly apparent from the consumer groups that I interact with that the reason it says unknown is because they skip the question. They feel that there will be some judgment or retribution or ramification from disclosing their race. So that is a really big number. And something that, hopefully, DSS can put out some information or find a way to get that number lower. And I just wanted to put that out there, that if anybody is wondering why that number is so high, that's pretty much the reason.
And I'll just add a comment. I think from my experience, it's also that people don't always identify with being part of the race. they think of themselves as Puerto Rican but it's hard for them to figure out what to put, and sometimes don't want to because it's not how they identify themselves. It's a tough one to get through. It really is, because there are a lot of barriers to people filling that out.
So I just want to chime in because we actually did a bunch of research on this in the last year as we were working on standardized data. And what we found is that it's actually more likely that the provider skips the question than the patient. And so there may be some provider training that's needed. What we found was that when you ask people to identify and you show them categories that reflect the way that they see themselves, which hopefully the updated standards will do, that people are very willing to answer the question, and that a lot of these concerns were very small parts of the population had these concerns about ramifications. So, you know, it may be also worth thinking about how DSS is training folks at CHNCT at the, you know, at all the ASOs for doing the data collection.
Well, this information, as far as I'm aware, is based off of the Husky applications. So it's not providers. Once they've already gotten to the provider, they've already applied for and filled out. So Brad, correct me if I'm wrong, because it's the people served count. So this is all being based off of applications to be on Husky.
Yeah, and Susan's actually been, yeah, thank you, Kelly, and also Karen and Grace. And I think there's a lot of good, very important things highlighted that you guys have identified. And I think we are well aware that we are working towards improving this. And Susan probably can add a lot more, I think, helpful commentary here, but I think we're well aware of the need to improve this information and are very interested in doing so, though acknowledge that it's somewhat of a slow process to change how we're collecting it. But you're right, it's mostly eligibility related information where this is being collected. There is separate data that's sometimes gathered as part of the ASOs, but that's not reflected here. Susan, I'll pass it over to you because you can add a little bit more information.
No, absolutely. And I do appreciate everyone's insight on this. And it's very much an issue that we are examining and working towards improvement, because, you know, clearly the quality of the race ethnicity data, I think, is critical to the usability, the actionability of some of these data. So we really are trying to figure out where some of the issues lie, and also what options we can potentially employ that would support greater, you know, increasing, you know, folks providing data in instances where they're not, or understanding what may be the etiology for the unknown. So very much, you know, Kelly, to your point related to people's reluctance, we have a data governance group, and we have promulgated their draft recommendations that we're refining. But one of the things that we noted was that we were you know, concerned about whether or not some folks may not feel comfortable providing that data, and could we do a better job of being very clear about why we collect it, how we use it, assuring folks that there, you know, it's not going to be used in a way that would, you know, negatively impact their ability to get benefits, and just really being clear about how it is and is not used, and hopefully provide a different level of surety to folks to feel more comfortable. While, you know, the majority of these data are coming through application, you know, certainly we do have other programs where folks where it could be kind of provider based. So you think about, you know, social work and protective services for the elderly, those data may be coming in from a provider. So we are also had in there is that we want to ensure that there's good training for folks both internally and externally in terms of the collection of race and ethnicity data and other demographic data. We know that that can sometimes be a challenge, and that sometimes folks, it sometimes can be the folks who are gathering that information who can insert a certain level of reluctance and hesitancy, which, you know, then sometimes can impact the ability to receive that data. So very much echo the sentiment that we want to improve the quality of those data and try to reduce the volume of unknown.
Thank you.
Maybe the only thing I'll add is just acknowledging that it's probably, and sorry, for whatever reason, my camera keeps zooming in and out on me here, but but just to also acknowledge that it's probably multifaceted in terms of, you know, obviously we have some people that are collecting this data on the behalf of others, some people are filling it out on their own. There's obviously how we're asking the questions, what the forms look like, what options there are to select, all the variables that I think have to be looked at to see like where can we improve, so that we really understand some of the health inequities, because obviously this drives a lot of our understanding and also your understanding and the entire state's understanding of how Medicaid and CHIP services and other services outside of that, including SNAP, TANF, et cetera, are impacting people, both from a race, ethnicity, which is obviously probably the most important thing we need to improve on, but also from geographic variability, et cetera. And so I think acknowledging is definitely an interest. And also just want to thank Karen and the Health Equity Solutions team for helping put together some larger forums for the state and thinking through how this is going to be done at a broader level, including some of the Yale folks that I know have been helping with that effort. So thank you guys. And then I see Bonnie, your hand up.
Thanks. Really love the interactivity and format, and that this is available publicly. It's just a really huge advance. I am wondering for the medical category, and in thinking about what was said before about even Medicare having presented recently, would it be possible to be able to have whether it's another drill down or just be able to know members who've accessed medical, who've accessed dental, who've accessed behavioral as counts?
We could certainly look into that. Absolutely.
May I make a comment?
Sure.
Thanks. I'm sorry. I don't have any idea where the hand raising is on Zoom and I can never find it. So I unfortunately have to chime in. This is Donna. If we have, who accesses what, I want to caution to be very careful what kind of access that you're looking at, because when we do reporting, when they say access medical services, are you meaning primary care services, specialty services? Are you including emergency services? I think that's an important factor to break out, because when we break it out in dental, it makes a much different presentation of the data. And then may I comment on the grid? I noticed the grid also, when I hover over an area, it doesn't speak. I don't know if this was just a graphical display right now and it's temporary, but I can't read the numbers because everybody knows my vision isn't very good. So if I'm on the screen and I want to look at a county like New Haven or Hartford, I can't tell what the numbers are because it doesn't speak. It's not, doesn't seem to have an alt tag label behind it.
Thanks, Donna. We'll definitely look into it. I'll just make in terms of, and I think Bonnie, kind of one of your questions here, this is more about it's less about actually who's utilizing. This is more of like who has the services, who's on, who could be receiving. And so that would be what we would reflect in terms of this, from at least the people served dashboard. I think what Donna raises is important in terms of access to services and who's actually receiving, which would fall more under our kind of the quality data components, rather than this is kind of more the people served who's actually who's receiving medical benefits, which could include dental, obviously, et cetera. So those numbers are probably going to look relatively similar, though obviously there's certain individuals who, for example, limited benefit groups will only receive certain things. And so there will be some discrepancies. Grace, let me turn it over to you. Or actually, Susan, did you want anything else before we turn it to Grace?
No, I just, I think it's, good to kind of hear what some of the, next level or next phases of interactivity that folks are wanting. So, we can certainly look at, some of that, because I think obviously this is a base dashboard. This is, kind of just some of your meat and potato fundamental information. And, therefrom we can look at what other disaggregations that we might be able to do, kind of subcategories that are available, to us. So that certainly is, I'm certainly appreciative to hear, other constructions that folks are interested in, and we can certainly examine, kind of those and where in the phases of this we can potentially look to employ those. or deploy those rather.
Grace, go ahead.
Okay, so along those same lines, when looking at the list of the different services that people are participating in, it seems like it would be useful for example, if you look at medical and you look at SNAP, the numbers are quite different. And I think if somebody's trying to get a good picture of sort of what services people are getting, why are they so different? Is eligibility different? I'm tossing this out rhetorically. Are the same people participating in the lower number and then others are not eligible and that's why they're not? So it seems like it would be really helpful to have some kind of, again, click on this and you'll learn more kind of thing, but what the eligibility levels are or anything like that that explains a little bit more of the dynamic of what's going on there. Particularly because with social determinants, you've got such interface between food security, healthcare security, housing security. So if people are trying to understand what's happening with this group of people, a little more information, it's asking a lot because we keep asking for all kinds of stuff, but it would be extremely useful for somebody trying to either just understand the status of the population or use it for, applying it to something, what the dynamic is here.
Thank you, Grace. Yeah, I'm sure some of these things, as Susan will say, will be easier to do than others, and may take some time to tweak this, but appreciate all of the feedback and thoughts. And some things I'm sure may or may not be easily realistic within, but obviously it's helpful to have the commentary at least so that we know where there's areas of interest and areas to change. Susanna, let me turn it to you.
Hi, and I apologize. I have a lot of background noise, but just two quick things. One is an earlier comment that I heard, but I just wanted to make sure got interpreted the way I did, which is that it's useful to know right on the site how often it's updated. I mean, I know we answered how often it's updated, but will that be visible so folks know when they're looking at it and what dates it represents?
I believe that can be done. I will have to defer to my technical folks, but I just sense that it would be possible.
And of course, I decided to speak when I'm at the loudest moment. But the one other question is, when you're looking at enrollment, it gives you a chance longitudinally to think about churn, but the numbers won't fully answer that, right? You could have tons of people drop off and tons of people join, and it could be a stable number. Can you tell churn from this?
I don't think you could. I wouldn't use it for churn. I wouldn't be comfortable doing that, to be honest. My team is looking into churn, so we are trying to do some baseline analysis of that. So that's in the works, more broadly in the agency. But I don't feel comfortable saying that you could adequately assess churn from these data. It's fairly complicated and nuanced, particularly depending on the program type. So that's an area that we definitely need to put a little bit more muscle in and have clear data to represent that.
Got it.
Yeah.
And I'll just add, I know that I think very clearly has, was raised early on in the process for the final report for the transparency board when we initially met. And so that's definitely captured there. It's just how easy it is to actually display that and make sure the data is accurate, that we know what we're doing. And I know Susan has come up and you've been looking at it. I know I've discussed with our eligibility team as well. It's just, there's some challenges with us doing it effectively, though acknowledge that it's a really important aspect of this at some point to include.
Yeah.
Larry, let me turn to you.
I just wanted to comment on Grace's points about the social determinants of health. that is one thing that CHN has been focusing on pretty diligently over the last couple of years. And I saw your comment, Grace, that you're going to have to drop off at 1:45. So I don't know that you will be around when I demo our SDOH dashboard, but perhaps we can get a static image of it, and Brad can share it with you post the fact here.
Thanks, Larry. Yeah, good point. And Grace, great, good question as well. But yeah, definitely that's part of what we'll hopefully get to look at shortly.
Yeah, thank you.
Other thoughts, questions, comments? Again, immensely helpful. Thanks for helping us kind of refine this. So very much appreciate it. Well, we can come back at the end if folks are kind of playing around with it and have any others. But in the meantime, let me turn it over to Dr. McGraw again, Chief Medical Officer for CHN-CT, our medical ASO, who's really helped, when I started, helped me understand kind of what CHN has been doing for a long time in terms of their dashboarding, has been really overseeing a lot of their dashboarding efforts, making them functional, things that we review internally on a pretty regular basis. And so grateful that he's here today to kind of provide a fairly high level of overview of a few things that we hope would be interesting and offer opportunities for conversation on that. So let me turn it over to you, and let me make sure you can share, because I may realize just now as I'm saying that.
Yeah, it says the host has disabled sharing.
Let me try now.
Okay, and I will try and share my actual desktop, because I'm going to be moving through different screens. Can you guys see this?
Yes, we can see your desktop.
And now you can see my home of all the dashboard home.
Yes.
I will minimize my video panel. Well, thank you, Brad, and thank you everyone for giving us the opportunity to present. One of my charges in my 5.5 years at CHN has been to help the organization take the reams and reams and reams of data, some 7 terabytes of Medicaid claims data, and not to mention case management data, ADT data, other forms of data that we have, and take all that data and sort of display it in ways that were interpretable and meaningful to end users. So we use 2 tools internally. One most people are familiar with, which is Tableau. The other one is less familiar, but is also an industry-leading business intelligence data visualization tool by the company called Chnct, called ClickView, and they have since updated to a new one called ClickSense, which resembles Tableau a whole lot more. But we'll start here with ClickView. And one of the first applications we used for ClickView was this UCA, which is our utilization and cost analysis dashboard, which we have shared trends in utilization and costs with DSS predating my arrival at CHN. One of the ones that we've developed since arriving at CHN, this is about 3 or 4 years old now, is this health view. And I will open that, and it may take a second to open. And if the technology gods are with me, you guys can see this?
Yes, we can.
Okay, so what we have done is taken all the claims data in the background and created a number of tabs here across the top for highly prevalent conditions in the Medicaid population, and then added a bunch of costs and demographic data. There are a number of filters I can use in the left-hand panel there. I can click the years, etc. So again, 2020 was this is all based on claims, so it's utilization dependent. And depending on the year I click, so if I click at 2022, obviously we have 2 months of data. All our numbers are very small. 2020 and less so 21 were impacted by the pandemic. So 2020 is not a good year to look at. If I look at 2019 data, and you see this all updates in real time. You see the number of members, the prevalence of each condition in terms of per 1,000 members, and the total paid. I can filter on I can filter on additional conditions. So if I wanted to look at any combination of these conditions, I can just highlight those, and I can click on whether I want active enrollment or not. So if I select yes, the numbers will change a little bit again because the members that are actively enrolled. There was very little change there because there's been very little churn because of the public health emergency and the not terminating folks. We have it broken down by program, and again, Husky A being the most prevalent, down to limited benefits where the numbers are negligible. The different races, I know the previous comments about race apply here as well, with unknown non-Hispanic being a significant portion. This reflects the overall percentage of all the members with one of these different conditions. So let's move into one specific one, and let's say look at diabetes. And as that populates, you can see some of the information that we have on here. In 2019, we had 54,765 members with a claim for diabetes. The average age was 54. You can see the breakdown between adult and children, the breakdown between type 1 and type 2 being much more common than type 1. We do get lab data, which we incorporate in this. We get it from Quest, as well as some that's reported in claims. And so you can see the average distribution for members with a diagnosis of diabetes with their hemoglobin A1C here, with what we want is a hemoglobin A1C 7 or less, which shows good control, which puts us, the majority of the members are with there, but there is significant opportunity above that. So if I were a case manager and I wanted to select everybody with an A1C higher than 10, I can do that. And then I could click on member details, which I won't do here because it would result in some PHI being displayed. I could download that into an Excel sheet so that the case management team could then start doing member outreach to those members. And again, once I've selected that, everything changes on here. So the numbers are much less. But again, still the breakdown of adults who have very poor control versus child, what percent of the type 1s versus type 2s. I could select any age range I want in here. Here's the distribution by age of the members in this cohort. Here are associated diabetic conditions such as kidney disease, eye disease, etc. And what we've built in over on the right-hand side are comorbid conditions. So obviously anybody with diabetes and hypertension, 72% of those in poor control have hypertension as a comorbidity, and 40% have obesity as a comorbidity. 35% report tobacco use. And then we look at some of the quality measures that we have for things like whether or not they had testing. So all of these numbers, because I selected a cohort for which I had an A1C level, obviously I have 100% showing A1C testing, but that's not the measure. I'm going to clear that. And so it goes back to the total denominator. And again, this is much higher because this is all the years. I haven't selected 1 year. If I select 2019 again, that should update. And then you can see my A1C testing for the calendar year, which I selected, which was 2019, at 88.9%. And then compared to the prior year, there was very little change on most of these. The number in poor control, which is greater than 9, the number who were screened, the percent who were screened for nephropathy, the percent who had an eye exam, et cetera, et cetera. So I will pause there and ask if there are any questions on sort of the what we can do from a dashboard standard for these specific conditions. I'm going to move on and show a bunch of different dashboards in a minute.
Go ahead, Karen.
Oh, just thank you. Just for context, are you showing these as potential for what could be in the public facing dashboard in the future? Or is this just an FYI of what information is available internally?
This is more of a FYI at this time. I mean, this is information we are interested in sharing in the dashboard. And so it is to hopefully inform. And so, you know, these are dashboards that CHN has produced that have not been developed for public consumption. And that's obviously part of the thing that we're trying to do over time is develop public consumption, public facing dashboards. And so this definitely can inform us. So Karen, if there's anything that you're like, oh, this is fantastic, or hey, I would redo this, definitely welcome that input on it at this time.
Got it. Thank you.
And we do share access to these dashboards with DSS, obviously, but again, because there's PHI behind these, which we haven't put any filters to block that. These couldn't be open to the public at this point, but yeah, just some of the visualizations that we've created to look at the Medicaid data that's available. Are there any other questions? I can show some of our geo mapping capabilities.
Susanna, go ahead while he's pulling that up.
Sorry, I was trying to unmute in time for the last visualization, but there was a variant. Sorry, is it easy, Larry, to go back to the last one? Because I can't remember the words that I was looking at that were confusing me.
Yes. Did you want the overview or the diabetes?
No, this is great. This population variance from year to year. Can you just say a little bit more about that?
So what we look at again is, I think if we go to like pre-diabetes, which we have here, at-risk glycemia, you know, this is it going up or down, right? So we have a lot of these things about, let me try and go back here and just select at-risk glycemia for the variance here. That should update. What we're trying to do is see if year over year, there is a trend, an upward or downward trend. So because I've selected conditions, now it populates, so it might be a lot better to see, but you know, this is the increase. Again, remember, this is claims-based, so it's directly tied to utilization. And I guess I would have to select a year. Oh, that's 21 versus 22. So let me just go to something more reasonable here. So looking at 18 versus 19 population variance, you know, ADD went up 204 members. So that's an increase of 56% because the numbers are very small. But the number with prediabetes went up by 5,374, which is a 37% increase, which is very concerning because these will, you know, a significant portion will will progress rather to type 2 diabetes. I can look at it at a per thousand, which is a different view because it looks, the one variable that didn't control for was the population growth in the last slide. So when I control it by averaging it per thousand, you can see very different results here. Obesity being the one that has increased, you know, the most. There's a cost variance, and then I can display it as a block chart. So that's kind of what we were driving at, was just year over year trends in individual conditions.
Yeah, and you spoke to some of the things I was thinking about, which is that, you know, some of these are based on how much screening we're doing. So seeing more might be actually better because it means we're screening more, right, and then the per thousand. So there's just, I mean, anyway, it's great to see this is available for providers. And I think, Brad, to your point, you know, clearly there's stuff here, you know, I think giving the public some sense of prevalence of various diseases within the Medicaid population would be really valuable. But there's some thinking that would need to be done about sort of what's giving useful information and how to organize it when it's not a provider about their panel, because then they know how often they're screened. You know, they have all the information that would help interpret these, and it would be a little bit different for public facing. But I do remember our discussion about some of these chronic diseases and their prevalence, because to the extent that some of them are preventable, seeing what's happening over time with the Medicaid population, if we can show it in a way that's understandable, would be terrific.
Right. And so here, here I've just selected what's the prevalence of diabetes by town. This is per 1,000 members, so you can see all of Hartford County is darker. New Haven County is a little bit lighter. The bigger circles represent the more number of members. I have it actually set up per 1,000 members now. So the dots reflect the prevalence per 1,000 members. So like Waterbury, 101.8 cases per 1,000 members, whereas in Hartford proper, it's 119. In New Haven proper, it's 107. And so I will stop sharing this.
To Bonnie,
Is there any other
while you do that? Yeah, Bonnie has a question, I think. Bonnie, go ahead.
Yes, just a quick question, and these are really terrific and really appreciate this, Dr. Magris. Building on what Susanna said, I guess I'm thinking that there might be value, since these can't be shared interactively, to have some snapshots, some PDFs, so that there might be ways to add those to what's being built for, for what is public facing, and then there wouldn't be the concern of the underlying PHI.
Yeah.
And
yeah, we've been talking, excuse me. No, we've been talking to DSS about, like, could we take some of this data and display it, but cut it off at a certain level so that the interactivity blocks being able to go down to the member detail level. I'm displaying asthma right now, right? But so the problem that we run into in some of the, that's been raised by some of the advocate groups is when you get to certain filters and you're getting 1 to 2 people per town in some of these areas, the smallest dots, it's 2 people with, sickle cell in this particular town. Does that become identifiable, right? Because you would never want to risk crossing that threshold. You can see with asthma, a different story, whereas Windham County has, as a whole, this is much less population based than it is, Hartford and Windham County then have the highest incidence of asthma, followed by New Haven County and then New London.
Great. And I think just highlighting kind of, even with the eligibility dashboard, just to, some of the work to make sure that you can't identify individuals, because this again is all tied back to that level of data, is obviously a really important part of this for us, since we're not, I think historically, we haven't been necessarily producing this, and CHN is doing this more for population health and other things internally than externally. And so we just have to be really careful as we develop this to make sure we're putting in those safety things. And Susan's been extremely thoughtful, and I know Krithika and her team as well, as we go through this process to make sure we are being extremely cautious with not making sure we can't identify Bob, as Susan likes to say. We don't want to be able to find Bob. Susan, does that sound right?
Yeah.
Very much so. So obviously, we will always be thinking about that, even with static representations, as Dr. Murrah suggested, that even some of these, even as static, you can potentially do some deductive disclosures even with static geospatial representation. So those are all things obviously we need to be sensitive to and be thoughtful about.
It does really help inform questions that can be asked, though, and even of possibly like providers working with CHN care managers to realize, the information that's out there and has already been synthesized with so much effort. It's very exciting.
Any other questions on sort of that dashboard? I can move on to some of our other dashboards, just provide another overview. So as you can see here in the ClickSense application, which is again more like Tableau, we have a number of like major categories here, and so I'll just highlight some of them. For example, for attribution, if I click on this dashboard, it'll tell you when the attribution, the date that the attribution was created. And again, it says we have, you know, as of the last run, there were 977,000 eligible members, because we include dual eligibles, and we exclude dual eligibles and exclude anybody who has commercial insurance. So this is not the full number of people who have Medicaid, but the full number of people with only Medicaid. So of that, 655,000 are attributed to a practice setting. You can see the breakdown, FQHC versus glide path, which are the new practices just coming into a PCMH status, non-FQHC PCMH statuses, and then the 10% represent the non-PCMH community practices. We have breakdowns, as you can see, by everything, by age, by county, by program, race and ethnicity, adult, child, everything is on this dashboard. And I hope I don't ever display. I will go back. Some of the other things we've done, every engagement campaign that we do has a ClickSense. So we can, if we send out a mailer or we do a phone call to the general membership to say, you know, get your screenings done, we can follow the impact of that. We have one dashboard here called Gaps in Care, which looks, again, it's looking at those folks, not just the HEDIS measures, but the ones that have the gap, so that we can see where are the gaps, and we have the different measures. So this one is looking at avoidance of antibiotics. So we track the rate that we have over time, where we are. We have the breakdown by race and ethnicity, program, again, practice setting, the actual practice, whether they're PCMH plus or not, gender breakdown, whether they've been engaged in ICM, whether they were touched by a community health worker, a transition of care coordinator, whether they're enrolled in a behavioral health home or not, which is important for some of the measures that focus more on BH condition. And then here, what attribution tier they're on. Tier 1 is the most important one because that's one of the 4 PCP specialties, but we look at other forms of attribution, which are just other usual sources of care. For example, somebody who is a PCP but hasn't attested with the state falls into tier 2, and tier 3 are folks that are in a specialty practice, such as OBGYN, or a member might only be seeing an endocrinologist and not a primary care practitioner for management of their diabetes. So that would count as tier 3 attribution. I think I have other measures here, so I can look at, let me look at some of the BH measures. This is follow-up after hospitalization for alcohol use disorder. You can see the number in a BH health, behavioral health home increase a little bit to 1.1. So I have this gaps in care for every single one of the HEDIS measures here. And I can get all of the same information in there as well. Moving on, I've got 2 pharmacists that work with me, and so they've created dashboards to look at things like the use of opioids during pregnancy. This has been running for probably almost a year now, and we are identifying the practices and sending them letters with the members with information that they've prescribed opioids during pregnancy and all of the resources available. This one is one of the behavioral health measures that we're actually working on, which is screening for cholesterol for members who are on behavioral health drugs that can cause metabolic disturbances. And so our pharmacist is actually doing individual outreaches to those members. Our quality of care dashboards are our significant safety event dashboards. So as safety events are reported to us, mostly by our nurses in the hospitals, we do an investigation in quality. And then we report the severity and what event type it was. Like, was it a surgical site infection? Was it, and how severe was it, from 0, where there, upon investigation, there was no quality of care concern found, all the way up to a number 4, which is a permanent harm, disability, or death. And that's from evidence-based literature on peer review. Since the onset of the COVID pandemic, we've looked significantly at COVID utilization. So I'll just run through that one. So since the start of the pandemic, there have been 171,000 ER registrations or hospital registration events. And this is based on ADT data that CHN gets from the hospital through an agreement with CHA. We're reporting over 8,000 inpatient admissions, some 35,000 ED visits, and some 31,000 outpatient visits. The number of discharges from facilities, this has now impacted all 27 hospitals in the state. And this is the number currently inpatient, and the dots represent where the inpatients are right now. And then the heat map showing how many of these ADT events have occurred in each of these zip codes. You can see the number of members in the facilities over time, the total number. So it's interesting that in the first graph on the top, that you see the initial wave right here, which really didn't impact Husky that much. Because again, this was more elderly, and so we don't have a lot of Medicare. We don't have the Medicare. We don't always get the Medicare dual data from the hospitals. So this was mostly just straight Medicaid. Then you can see the Delta wave and then the Omicron wave. So pretty interesting storytelling there from that data. We have this data broken down by race and ethnicity, by member age across the bottom, by their program. So again, Husky A, Husky D being the most, by gender. That's just another graphical interpretation of the data that we've done. Their ICM status, whether or not they were, and we did that because we've developed an ICM. Oh, I'm sorry, this is, so going back here, looking at another interpretation of all the data that we've gotten is taken all that information. This one might take a little bit longer to open. We looked at some of the confounding the co-occurring conditions, and this one doesn't seem to be opening right now. And so we were able to see that if you had hypertension or obesity, you were X times more likely to have complications of COVID. Here we go. That took forever. So you can see we have all kinds of breakdowns on the month of the initial hospitalization, how much was spent, what was the spend. These are patients that had a diagnosis of COVID and did not have a hospitalization here. We have, if I just move through some of these other dashboards here. This one has a lot of data in the background, so it takes a long time to load.
Any questions, feel free to raise your hand and as this is loading.
And then what we looked at, because there's member data on that. Here's again, total numbers of members. We looked at the cost. What we were trying to do here is identify members who had developed a chronic condition after having COVID versus members who had a chronic condition prior to getting COVID, and comparing the cost pre and post COVID for both of those cohorts. And one of the reasons for that is that we created a new ICM program around COVID with complications or COVID long haulers. And so this was the tool that we used for identifying those members. I'll close out some of these. And then lastly, I think I wanted to show our social determinants of health dashboard. This is an interesting one. And for 4 years, I was asking if we could start to aggregate data from all the multiple different sources that we get information, SDOH information from. If we could start to sort of aggregate that data from all these. I'm trying to avoid clicking on the ones. Here we go. I found the right one. So what we get SDOH information from claims, which is using Z codes, from our customer resource management system, because every time a member calls into our customer service center, they're asked if they can be asked questions about social determinants of health. And if they answer, they can get a referral from one of our community health workers or from one of our ICM nurses. We capture, some of the information is captured when our care managers do health assessments, and this GC refers to the guiding care platform that we use as a care management documentation tool. Some we get from health risk questionnaires, which are member self-assessments, and we get some from the OB Pay for Performance program that the OBs report them on the sheets they are sending. So we had to aggregate data from all these different sources and then come up with a nomenclature. And so we went back to looking at how the claims represented. There's breakdowns for housing and then social environment. And under social environments, there's subdomains. So it might be, upbringing, education. Some of them, like food insecurity, would fall under housing here. I'm sorry, under nutrition here. Employment, translates across of these, but these are the main domains that we report, and then these are all the subdomains. So we have that level of detail. We have the total number of cases by who engaged them, whether it was a transitional care coordinator, whether it was a community health worker or an ICM. We have the number of members over time. And then we're also in a pilot with Unitas, which is a referral, an electronic referral system that allows the case to be tracked until it's closed. So if someone is referred for food insecurity to the food bank, that would be an electronic referral. And then the food bank would be able to close the referral and send back information to CHN about what was provided for the member, so that we are able to get that closed loop on the closing of the loop on the referrals that we send, and get that feedback back to the care manager, social worker, or CHW that's addressing the member. And again, we have all the demographics. We have had, using this over a 1-year look back, we've had about 48,000 members who reported at least one SDOH in the last year. Of those, about a little under half have multiple SDOHs, for a total of almost 89,000 individual social determinant of health issues identified. Unique households, et cetera, broken down by practice setting, the source of where we got the information, et cetera. So we're, again, using this to really look at where the biggest needs are, and so that we can work with DSS to, start to address those needs in the population.
Is there any questions?
I overwhelmed everybody with too much information.
I just wanted to excuse me. I just wanted to chime in and say it's really exciting to see Medicaid putting all of this together, especially as we do the cost growth benchmark work and think about how we should be outlining our dashboards and what kind of information to capture, especially the social determinants of health data. I think that's really, really, really interesting. So just thank you for being here today and sharing.
My pleasure. Thanks for having me.
Thanks, Kelly. Any other questions? Seeing none, we can kind of go back to slide. Hopefully folks can see this. So just kind of some next steps on the DSS. And again, big thank you to Dr. McGrath for presenting today. We have as you guys know, relatively small team of folks working on this at the moment, at least internally at DSS, not commenting on the CHN's team. And so we're going to be in the process of pivoting to both quality and financial dashboarding, which I know has been a big part of even just the basic launch. And so those components are under works, and I'm hoping we can have something, again, just a reminder, the quality ones will really be static initially. So they're not going to be like the person served set dashboard, we're able to drill down and do other things at this time. The financial dashboard hopefully will have more ability for that, but it takes a little time because a lot of our data is really geared towards internal use and will take some time. There's some challenges with making sure it's both understandable and we can publish it in a way that makes sense to the public. So that is, we do have some data we're ready to start working on, just acknowledging that may take a little while for us to process. There's some other conversations about working to expand the internal team so that we have some more resources to do this work, which we definitely could, I think, utilize to get it done slightly faster time frame, acknowledging that there's challenges with also getting those resources for these purposes, both for ongoing development, but also maintenance. Because I think, as we know, and as we're just talking about, feedback for the existing dashboard that was just, you need someone to make sure the data is being refreshed regularly, that we're, modifying it, we're taking feedback and updating it. And obviously that takes some time and some work. Susan, I don't know if you want anything else, any more commentary to that. Just want to make sure you have the opportunity to, if you'd like.
No, I think that's, you summed up kind of where we are with things, and, and definitely can't underscore enough the importance of wanting to have that ongoing maintenance piece. What I think would be tragic would be to put these up and not have a mechanism to have that ongoing updating, certainly to the data, and then obviously thinking about user experience. So that is definitely something that we're focusing upon, and do have a solid plan, at least to make sure the data is being updated on a regular basis.
Great. So really, I think for today, that's pretty much it. We wanted to make sure to at least provide opportunities for feedback, which we'll take back, and also just to kind of preview what's happening at CHN. Again, thank you. Our next meeting, we'll have Bert Plant from Beacon to present the behavioral health dashboard that they've also put together. So just to kind of give you a flavor for all the different components, and just also obviously acknowledging that, this is one of the things that we're interested in is getting something functional that can be public facing again, so that we're not, displaying our members' data, but so that it's actionable and useful and timely. And so I know it will be an ongoing work in progress, but we appreciate all of your feedback and engagement. So any final questions, thoughts?
I have one question, and just, in the context of respecting what an enormous amount of work this is, I'm wondering if there's a timeline for when the next phase might be ready to share.
Great question. I don't want to overcommit. Susan, I'll ask you if you have
I don't. I think we really do have to have some internal discussions, including Krithika's on the technical side. In terms of, more interactivity, that's further down. In terms of the static dashes, I think that's obviously more tenable. I think there's just still a couple of pieces that we need to iron out with respect to that. But those, I think that creating those can certainly be done more quickly. and potentially even some of the financial pieces that Brad mentioned once we have a couple things sorted out there. But I don't have I think we just need to take that back and have a little more discussion, Brad, about what we can likely get out in the near future.
Bonnie?
Thanks. Just a quick question or request for possibly the minutes or even the agendas or information that gets posted. There's such a wealth of information and internal structure that I just think it might be helpful to post if there's a best contact at Medicare or at CHN for interested providers who have a follow-up question or other folks from the community, just to help especially steer folks to information that might already be available to them.
Yeah, I mean, I think what was talked about today isn't necessarily available, which I know is part of the reason we're trying to make it available in the long run. And so usually that information will be, things that are available will be either publicly reported at a MAPOC or MAPOC subcommittee or something along those lines where those will get posted, which is often there's data that's published or put out there. You're welcome to, in the meantime, if there's a specific question, I'm happy to try to help field it and figure out, but I know that doesn't really get to your question. I think in the long run, that's part of the goal of this, is to make this data more accessible and available so that it is something that you could go and search or download some of the raw information, obviously not at the member level, but that's definitely, I think, in the long-term part of this, the goal of this. So just to say, I'm not sure we don't really have a great solution for kind of fielding tons of data requests at the moment, I would say, if that makes sense.
And I'm sorry, I didn't mean sort of individual requests, but I'm thinking it might be good, let's say in the minutes, to have the Husky Health portal for providers where there is data and reports available with, for folks who, especially for providers who may sign up for them. It just as an example, or if folks should contact sort of the care coordinator for their area. I'm just thinking for whether when there is data or a system already available, it might be helpful to share that information.
Thank you, Bonnie. Okay, I think with that, we will wrap up. Again, thank you guys for continuing to be with us, and definitely appreciate you guys. And Karen, your question about when's the next step launching, we appreciate that prompt. I think we are very interested in seeing it get live as soon as we can, but appreciate you continue to kind of encourage us to get there sooner. So we look forward to the next conversation in May, and if we have anything sooner to announce, we'll make sure to send something out ahead of time. Otherwise, thank you all again, and touch base in hopefully the not too distant future.